Hi everyone, this is chapter 9 of Oral Anatomy. Luckily it's a short chapter too. Clinical considerations. We've talked about some of this already, but we're going to analyze the dental conditions that are involved in recognizing potentially pathogenic situations. What can go wrong? What can cause damage? And then also, we are going to be learning throughout your education how to apply appropriate preventive therapeutic treatments. So you need to have a good understanding of periodontal disease as well as the decay process. And that is a lifelong learning. I'm still taking courses. I'm in a course tonight on saliva, and it's a 4-part course. So we never stop learning. But the smoothness of the enamel, okay, the enamel portion of the tooth, which is the hardest part of the body, okay, makes adherence of dental plaque more difficult. However, it's still going to cling. So it has some self-cleaning capabilities to help resist decay. Now that's the smooth part of the enamel, but to some extent it also aids in the prevention of periodontal disease because the bacteria that destroy the gum and the bone tissue are also prevented from hopefully accumulating on the tooth itself. But as we know, it doesn't work that way, okay? Neglect is neglect. But your teeth have pits, grooves, and fissures on a tooth that provide a breeding ground for bacteria. Yes, they act as spillways, but they can also be a breeding ground for bacteria. Rough margins or overhanging interproximal restorations are also plaque traps. They harbor debris as well as bacteria, and you can just imagine what's going on underneath these horrible restorations. So rough restorations should be polished smooth. Tooth sealants should be placed on deep grooves to help to prevent tooth decay. Okay, so we have prevention. Rough restorations, we used to polish amalgam restorations as well as remove overhanging restorations. That was part of what we did as dental hygienists. Now we refer them to the dentist to say, please fix this. But the goal of the dental professional, and that's you and the dentist, is to remove calculus and smooth rough areas of the root, right? That's what we do. This root cleaning is sometimes called root planing or root debridement. The cementum, you have to remember though, is thin and it's easily stripped away during root planing. So this can result in the patient having sensitive teeth, sensitive roots, because we've stripped off that cementum and exposed dentin. So again, we want to avoid creating problems. But the hardness of the enamel really helps prevent occlusal wear or attrition. Tooth to tooth wear is called attrition. That same hardness allows for the full impact of trauma to be transferred from the tooth to the bone. Our bite is very hard and it is very forceful. So there's something called occlusal trauma. And if a tooth prematurely contacts one another, then only those two teeth are going to bear the initial brunt of the force. That's occlusal trauma, and that can result in the disease process of cracking the enamel of the teeth, of cracking the tooth, and possibly fracturing the tooth itself. And when we're talking about the periodontal ligament space, you can see this tooth here, that widened PDL around the entire tooth. Contours of the teeth. So if the buccal and lingual contours are underdeveloped or undercontoured, then food and debris can actually be pushed into that gingival crevice. And if the buccal and lingual contours are overdeveloped or overcontoured, then food and debris is going to pass off the tooth onto the gingiva at a poor angle. So if the tooth contour prevents extreme undercuts, then the natural cleansing action of the tongue and the cheeks becomes ineffective. So when the tooth is being restored, it's important for the dentist to be able to replicate the anatomic position of what that tooth was meant to be. So to do that, they use something called a matrix band. If you have a tooth decay in between two teeth, a band goes around the tooth with a little wedge or widget to mimic that contour, and then it can be shaped. So the tooth should be maintained in its original form. Pulp tissues, if you've got bite discrepancies, can become inflamed during the placement of a restoration. If the restoration's too deep, the pulp tissue can't expand. Remember that pulp tissue goes to the apex here and then to the blood supply. This pulp tissue is next to dentin, which is hard. So this doesn't have any give, so it doesn't expand. If you've got inflammation of the pulp, you have pressure that builds up within that pulp cavity wall. It's got no place to go. So the pulp tissue begins to close off at the apical foramen, at the tip of that root. And when that occurs, the blood flow is stopped, and it results in the death of the tooth's pulpal tissue. So as inflammation occurs, this opening here gets pressed down. Blood flow stops. The tooth stops living. So a patient's bite is checked after a restoration is placed, and they bite on something what they call articulating paper, all right? And it's like old typewriter ribbon or something, but they bite, 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 chew, 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 grind, grind, grind. And this is done to ensure that no part of the restoration is hitting prematurely. The problem is most patients are laying down when their bite is being checked, and the occlusion changes just a little bit when we're laying down versus when we're sitting up. So the patient really should be seated upright when we're checking the occlusion. So the dentist needs to maintain proper bite in restorations. Okay, so there's no premature contacts, because a premature contact can lead to a sore tooth, which can lead to inflammation, which can lead to pressure and swelling within the tooth that pushes the tooth out of the socket a little bit, that inflammation. Then the tooth now extends farther from the socket, and it hits the opposing tooth even sooner and harder. So it's important that this be checked and that an occlusal adjustment or a bite adjustment take place, because the damage could be irreversible. Now, the nerve of the tooth only experiences pain. So that nerve centers within the tooth, okay, are only capable of eliciting pain. You need to know that. So if trauma or infection from any other source is present, the nerves in the supporting structures and around the tooth are going to respond to pain. The nerves within the periodontal ligament, the periodontal tissues, can give either a pain response or a pressure response. So your PDL has some sensory capabilities as well for pain or pressure, but the nerve of the tooth can only feel pain. So if the dentin is exposed and you're blowing air, or the tooth comes in contact with sweets or temperature, that can be a painful stimulus for the patient. Tooth migration. If the tooth is fractured and no longer there's no tooth next to it to chew with as early as 24 hours, that tooth can begin to migrate. So when a patient loses a temporary crown, for example, it comes off, you want that patient to come in as soon as possible to get that temporary placed back in, because that super eruption is going to take place within 24 hours. And by the time the patient 2 days later comes in to get that permanent crown seated, that occlusion is going to be way off. So, and that's just what I said. So if a tooth is removed and not replaced, the tooth in the opposite arch begins to supra-erupt, erupt past the occlusal plane because it's trying to meet an antagonist. When the contact areas are changed, then food impaction can occur because of the super eruption. Teeth want to be next to each other, not only side by side, but from top to bottom as well on opposing arches. So they begin to migrate, trying to find a mate. One of the phenomenons is called mesial drift. So this tooth, the maxillary molar, is supra-erupting as this molar on the mandibular is trying to drift mesially. You can see this premolar is actually drifting distally, but that's because of the biting force here. The bite is causing that. Premature occlusal contact can occur in centric occlusion with mesial drift. Centric occlusion, how do the teeth bite together? Occlusal trauma results in mobility of the affected teeth and finally tooth migration and then tipping of the teeth. So tipping can result in the loss of the lamina dura radiographically and then the formation of infraosseous periodontal pockets. As that tooth tips, the bone is going to be destroyed. So the patient is going to bite differently. That can put pressure on the muscles and on the temporomandibular joint, and they could end up with pain that way as well. They tend to favor the other side that's not painful. So preventive dentistry is really there to maintain the oral structures in the most mutually protective harmony. And that is clinical considerations.